My name is Jim Stavropoulos, and I will be speaking about the role of genomic diagnostics in personalized medicine. I'm presenting this hypothetical clinical scenario in order to illustrate the utility of genomic diagnostics. In this case, there is a child that appears to be normal at birth, however has delayed development by 12 months of age. The child has severe seizures, sleep disturbance, neurological deficits that affect coordination, uncontrollable jerky movements, and the child has severe learning difficulties and does not develop the ability to speak. Some of the clinical management issues that may arise include choosing the most appropriate and effective medication in order to treat the child's symptoms, providing a prognosis for the future health of this child as he develops, and also providing a risk estimate to the parents of this child of having another child with the same syndrome if they decide to have additional children. Now, in order to manage these issues most effectively, the clinician must have the ability to obtain a diagnosis to understand the underlying etiology of this syndrome. The conventional hypothesis-driven approach involves ordering tests for recognizable syndromes that overlap with the child's clinical features. This may include genetic tests for syndromes with overlapping features, biochemical testing if a metabolic disorder is suspected, as well as chromosome microarray analysis in order to try to identify whether there is a deletion or duplication in the genome that's responsible for the child's syndrome. This stepwise approach is costly and time-consuming and can result in a diagnostic odyssey for the child and his parents. And we know that as many as 50% of cases never obtain a diagnosis. I'm going to speak a little bit about the diagnosis of neurodevelopmental disorders. Neurodevelopmental disorders and congenital anomalies affect approximately 5% of the general population, and this represents a heterogeneous group of disorders that can be caused by thousands of different genes. Chromosome microarray analysis has become the first-line test to diagnose these disorders, and it can identify causative copy number variants in about 10 to 15% of patients. However, negative cases often have additional genetic testing, which may include single gene or gene panel sequencing, exon-targeted copy number analysis, or whole exome sequencing. And this stepwise strategy is time-consuming and costly. Whole genome sequencing can detect virtually all forms of genetic variation, including copy number variants, single nucleotide variants, and small insertions and deletions. And we believe that whole genome sequencing can provide a significant increase in diagnostic yield, where chromosome microarray and other routine testing is currently the standard first-line diagnostic test. So this next slide shows a evolution of chromosome microarray testing over the years. Initially, in the early 2000s, chromosome microarray analysis was considered to be kind of a genome-wide test. However, as you can see by the dots along this chromosome histogram here, there is only, which actually represent the probes, there are only probes in regions of the genome where we knew disorders associated with developmental congenital anomalies were caused by deletions, duplications in these regions. And so the idea was, since we didn't know how to interpret deletions and duplications in the rest of the genome, we didn't have probes there so that we didn't detect them. However, we quickly realized over the years and implemented tests with higher resolution microarray analysis in order to detect copy number variants anywhere in the genome, so that we have a maximum ability to obtain a diagnosis in these patients. As such, we would come across regions of the genome that we may not have tested previously. However, if there are a sufficient number of genes affected or genes that we know can potentially cause disease when deleted or duplicated, then we are able to obtain a diagnosis. Okay, so this is an example of the diagnosis of recognizable syndromes while we were doing microarray analysis in the early days. And so when microarray analysis was first implemented as a clinical test, the standard of care was G-banding analysis, but also physicians would order FISH analysis to detect deletions or duplications of regions in the genome that are known to be associated with a recognizable syndrome. And so a good example of this would be 22q11.2 deletion syndrome, So this is where if a physician sees the patient and the patient has clinical features that are consistent with 22q11.2 deletion syndrome, then the physician would order targeted FISH analysis for 22q11.2 chromosome region and would not test the rest of the chromosomes. And what we found was that when we were doing microarray analysis, we would be doing it for patients where the physician had exhausted all other testing. So if they had suspected 22q11.2 deletion syndrome, they would have tested for that using FISH. But if they don't suspect it and they've done all other testing, they might order microarray as a last-ditch effort to obtain a diagnosis. And what we find is that often, and in this situation, about 2.5% of cases where we obtain a diagnosis in microarray, it was actually a diagnosis of deletions or duplications that cause apparently recognizable microdeletion or microduplication syndromes. And so what this tells us is that although the child had a recognizable syndrome, the clinical features that that particular child presented to the physician were not enough for the physician to identify that as a syndrome that might be affecting the child, and so the test wasn't ordered as far as a targeted FISH test for that particular syndrome. And this is because of the clinical variability of these syndromes, because patients with recurrent microdeletion or microduplication syndromes can have very varying severity and expressivity of the disorder. But also we find that we were able to obtain early genetic diagnosis before these syndromic features develop, which are associated with these recognizable syndromes. But when we do microarray analysis, because we're interrogating the entire genome, we also find many more rare deletions or duplications that really haven't been described previously because the breakpoints will differ from one patient to the next. And this is an example of extremely rare copy number variances where we identified a novel disease genes caused by deletion. And so this is basically a summary of testing of over 42,000 patients by microarray analysis, where only 4 of those patients ended up having a deletion that included the CHD2 gene. And so when we performed microarray, we found that this deletion affected CHD2, and since CHD2 is related to other genes that are known to cause syndromes, such as CHD7 is associated with Church syndrome, it piqued our interest as far as potentially being causative in the child's phenotype, which was related to seizures and developmental delay, as well as autism. And however, within our own experience, it was the only case that we had known about. And so we had contacted other clinical diagnostics labs that run a microarray service to see if there were other deletions that affect CHD2. As you can see in this illustration here, there is these blue lines represent where the deletion occurs relative to the gene on this chromosome that we detected by microarray. And so there's the patient from Sick Kids, and then there are other patients that were contributed by St. Justine, Calgary, Guy's and St. Thomas, NHS. And then there was 2 cases that we found in the literature that overlapped with CHD2. And so then what we did was we looked at the clinical features of all these patients that had partially overlapping deletions that affect CHD2. And what we found was that there was some overlap. So there was language delay, autism, intellectual disability, seizures, mild hypotonia, and auditory neuropathy in at least 2 or more of the patients. We also found that these deletions were de novo in all but one of the patients who had this deletion. So this evidence suggests that this deletion that affects CHD2 is potentially or likely pathogenic. In addition to the findings that we show by microarray analysis, where deletions of CHD2 cause seizures and intellectual disability, as well as autism and other features, there was a publication that showed that CH2 sequence level variants are associated with epileptic encephalopathies. So in this study, They had 500 patients with refractory seizures and cognitive arrest or regression, and they performed NGS panel testing for 19 known disease-causing genes as well as 46 candidate genes. And what they found was that 6 out of the 500 patients showed de novo pathogenic variant in the CHD2 candidate gene. 4 of them were loss of function mutations, and 2 were missense mutations in highly conserved residues in the helicase domain. And since these were all de novo, in addition to the expected pathogenicity of these variants, they were deemed to be causative for the features in these patients. And so, in contrast to the copy number analysis by microarray, we showed that deletions of CH22 are extremely rare. So there are only 4 patients out of 42,000 tested who had neurodevelopmental abnormalities, whereas patients with a more specific phenotype and where sequencing analysis was performed, they found that 6 out of 500 patients actually had pathogenic variants in CH22. And so both sequence level as well as copy number variants are clinically relevant in diagnosing these patients with neurodevelopmental abnormalities. And again, speaks to the idea that a comprehensive genomic test detecting both sequence level as well as copy number variants is probably the best approach and provides the best opportunity to obtain a diagnosis for these types of patients. Now, in more recent years, whole exome sequencing has been a commonly ordered test for patients with rare disorders, and which include patients with neurodevelopmental abnormalities or congenital anomalies. And this is an analysis of virtually all of the genes in the genome, and specifically targeting the exons of those genes, and performing sequencing analysis of those exons. And so this is an analysis of over 20,000 genes. The clinical features are associated with a high degree of genetic heterogeneity in the patients who were tested. And differential diagnosis may include multiple genetic disorders not covered by a single genetic test. It may be ordered for patients who do not reach a diagnosis by standard genetic testing, which may include microarray analysis. However, a comprehensive analysis such as whole exome sequencing does have a significant chance of identifying a medically actionable diagnosis not related to the patient's symptoms. And so this might be, for example, a pathogenic variant in BRCA1 associated with adult onset breast cancer, whereas a patient was referred for whole exome sequencing for a diagnosis for symptoms associated with a neurodevelopmental disorder. However, the patients typically have an option regarding disclosure of secondary findings when they're tested by whole exome sequencing. This test can also identify findings related to pharmacogenetic findings. Whole genome sequencing is more comprehensive than exome sequencing and microarray combined. Whole exome sequencing provides a diagnostic yield typically of approximately 25 to 30%. And as I mentioned earlier, microarray analysis provides a diagnostic yield of approximately 10 to 15%. Whole genome sequencing can detect single nucleotide variants, small insertions or deletions, balanced structural rearrangements, copy number variants from less than 1 kb to large chromosome imbalances, and has the potential to detect clinically significant variants in genetic regulatory regions and non-coding RNA that are not typically sequenced by whole exome sequencing. It's a comprehensive analysis that can identify virtually all genetic variants in a single individual to enable personalized medicine. This study was performed to investigate the diagnostic yield of whole genome sequencing for patients referred for microarray in a pediatric hospital. We performed whole genome sequencing in parallel with chromosome microarray analysis on 100 consecutive prospective patients referred for neurodevelopmental disorders and or congenital malformations. This slide shows the size distribution of copy number variants from whole genome sequencing compared to what was found by chromosome microarray analysis in these patients. And so this basically shows the cumulative copy number variants placed in different size bins along the x-axis here. And this is the total number of variants identified within each size bin on the y-axis. And so the blue line basically represents the number of copy number variants within the particular size range identified in 100 patients by chromosome microarray analysis. And then the green line basically shows the size distribution of copy number variants identified by whole genome sequencing using the read depth method. And then the red line shows the copy number variants identified by whole genome sequencing detected by mate pair mapping and split reads. And this table here shows that chromosome microarray analysis had approximately 7 copy number variants per patient, and they have a mean size of 366 kb and the median size of 116 kb, whereas whole genome sequencing read depth method had over 250 variants per patient with a mean size of about 30 kb. And then the structural variation detected by mate pair mapping and split reads showed approximately 1,500 or more variants that had a mean size of 14 kb and a median size of 496 base pairs. And so you can see that whole genome sequencing detects many, many more structural variants and copy number variants as compared to chromosome microarray analysis, which basically presents a challenge in being able to interpret all of the variants that we're detecting in these patients. Importantly, the majority of the copy number variants found by whole genome sequencing are well beyond the resolution of chromosome microarray, which typically has a resolution of detection of about 20 kb. When we look at a summary of the types of variants that presented a diagnosis by whole genome sequencing, we found that the whole genome sequencing identified a diagnosis in about 34% of patients overall for both copy number variants and sequence level variants. So 8% of patients had a diagnosis by microarray alone, and that increased to 13% of patients when you look at patients who had microarray as well as any routine genetic testing such as gene panels or any other genetic testing. Whole genome sequencing resulted in a much higher diagnostic yield than chromosome microarray analysis and routine genetic testing. When we look at the clinically relevant sequence level variants, and you look at the distribution of the types of variants among patients, we found 28% of patients had clinically significant single nucleotide variants or indel mutations, and 63% represented a dominant disorder and 37% represented a recessive disorder. We also found that 4 out of 100 of the cases, so 4% of cases, had variants in at least 2 genes causing distinct genetic disorders. And so this basically, in summary, shows how performing whole genome sequencing can provide a more comprehensive diagnostic test to truly understand the clinical symptoms associated with a particular patient, and is more comprehensive than chromosome microarray analysis or whole exome sequencing alone.